I will introduce Marcos Maldonado from Santiago. The talk speech about therapeutic adoption of Teleneurorehabilitation program with a design of exercise clusters related to the complexity-based model for categorizing rehabilitation. Preliminary results.
Good morning. I apologize because I read my notes, but I prefer that the information will be more clear for you. The title of this study is the Therapeutic Adoption of a Teleneurorehabilitation Program with a design of exercise clusters related to the categorization model for complexity in rehabilitation. In physical medicine and rehabilitation service of Clínica Alemana, we began a telerehabilitation program for neurological and vestibular patients with alterations of balance and incorporate virtual reality to carry out this type of intervention with the objective of giving continuity of care after the patient's discharge and being able to evaluate, design a treatment plan, and measure outcomes objectively. Virtual reality is a rehabilitation tool that has the ability to provide augmented feedback during the repetitive practice opportunities within a controlled and motivating environment, which can enhance the efficiency of motor learning as well as patient compliance with therapy. Therapists often have the ability to set the level of challenge presented within virtual reality activities for their patients by modifying the characteristics of the virtual environment. Thus, enable gradual increases in difficulty while promoting safe and successful participation. Therapists are being asked more frequently to incorporate this new intervention approach into practice. However, there are factors influencing the adoption of virtual reality by therapists. The concept of adoption is extracted from the extension of the theory of playing behavior, which aims to predict an individual's future behavior based on his or her intention to carry out that behavior. The theory also aims to explain the behavior based on the individual's beliefs about various factors or determinants influencing his or her intentions. According to the theory, the three primary determinants of behavioral intentions are attitude, is related to self-efficacy, social norms, which reflect the relative influence of peers and superiors on behavior in the workplace, and perceived behavioral control is related to perceived usefulness and perceived ease of use of the technology. Virtual reality implementation research is at an early stage. Clinicians are direct mediators of their patient access to virtual reality. Hence, the factors influencing therapists' intention to use the technology are paramount to the implementation process. Facilitators and barriers appear to be the most commonly discussed construct, while less frequent but recurring factors in the literature, such as the need for training experience, perceived ease of use, and social norms, have been less studied. So, this study identified the barriers and facilitators in the use of virtual reality and how they influence therapeutic adoption. The barriers identified are time to learn, time to use, lack of suitable clients. The facilitators identified are client motivation, access to evidence, and colleagues with expertise, among others. We acquired the virtual reality RehaMetrics software, which we use in the clinical environment and at patients' homes. We don't have conflict of interest with them. We started using the software in the clinic. This allowed us to recognize barriers, facilitators, and we focused on learning the exercises in detail, programming and creating the protocol of rehabilitation. In this video, we can see the time used for programming a routine of therapy. That was one of the first barriers, time to use. Since these systems depend on a good Wi-Fi network, then we needed to enter the patient's information, and finally, choose from among more than 50 exercise options. Moreover, each of these options had various levels. Therefore, we took more than 20 minutes to program. This is another barrier that we found in this process: time to learn. After working with the patient, we needed to review the results and analyze them to determine the accuracy of the exercises selected. This software delivers a lot of information after training. Nevertheless, to generate a report, it's very important to know which is the purpose of the training selected. Only thus, a more exact analysis can be carried out. Our barriers were similar to the evidence reviewed, also our facilitators. Therefore, our objective was to facilitate the therapeutic adoption of a virtual telerehabilitation program using clusters of exercises related to the complexity categorization model used in our service. This study will be quasi-experimental and prospective scheduled for 2 years. We have divided into 2 phases. The first one we have almost completed. I will show you the preliminary results today. The second part we will develop during the rest of the investigation. The creation of the clusters of exercises had 2 purposes. To deliver previous analyzed exercise to the therapist to reduce time to use, to devise exercises according to improvement in balance skills to reduce time to learn. To know how this process is developed, it's necessary to know 3 previous steps. The first step was to identify a motor problem. The common condition that affects our neurological and vestibular patient is balance, which is affected by various factors as reactive postural control, cognitive factors, biomechanical factors, among others. The second step was to identify the main functional stage to work with our patients, that we divided them in sit to stand, standing, and gait abilities. This part allows us to start the training in early stages of recuperation because in all of these areas, balance could improve. The third step was to select a clinical scale extracted from the categorization model by complexity in rehabilitation. The scale chosen was the Minibus test, as it evaluates the dynamic balance in 4 subsystems that allow us to select exercises that our patient needs. Finally, based on this data, we will select the cluster of exercises that the patient will perform. The design of clusters was a proposal made from the research team. However, we needed to know if it makes sense for the team of therapists. We needed to involve them in the process to facilitate their process of adoption. The total number of therapists who participate in this study initially was 4. 60 clinical cases were designed, which each therapist should relate the clinical results with a cluster of exercises according to the Minibus test score. Before analyzing the degree of agreement between therapists, we divided them into expert and novices, according to the years of experience, use of this functional scale, and previous knowledge of the software. To identify the degree of agreement among therapists, we did 2 technical training sessions and 3 sessions to evaluate the clinical cases. The agreement was moved according to the kappa coefficient. It was identified that the expert only had 2 agreements in clusters 1 and 6. In the case of novices, agreement was accepted only in cluster 6. So, we decided to work the following phase only with experts. Then, there was a training meeting only with experts, and they agreed to reduce from 6 to 5 clusters of exercises, fusing the 3rd and 4th clusters because the understanding of exercises was easier than before. We found this study of Franchignon in 2015, who developed 5 deficit categories for balance in the minibus test and guided us to divide the stage of training according to balance deficits. The result of this process was this outline, so we choose any cluster depending on the score in the minibus test, which is related with a functional stage. Finally, each cluster has 5 exercises. Here, we can see an example of progression of the clusters. We can see the progress not only in the functional stage, but in the displacement of base support. The first 3 clusters have a static base of support, but the 4th and 5th clusters have dynamic base of support. Each cluster has 5 exercises per one. When the patient has better motor performance, we can upload to another clusters of exercises. We can see in the cluster 4 that the patient displays 2 lateral movements. In the cluster 5, for example, we can see that the patient progress in their effort. The results of cluster decision agreement among experts was more than 80% in a concordance test measured by kappa. Then getting these results, the experts are ready to train the novices. This will support more transversal knowledge about the program of teleneurorehabilitation. Here we can see the results more clearly. Here we can see the concordance between expert and the dispersion. So the impact of the selection of these clusters in the first part of our protocol. We can see in the protocol that with proper selection of exercise cluster allows us to optimize programming times. So this process would become a facilitator. In this way, we reach one of our objectives. We designed this protocol adding to the process of clusters for therapists to start to use this system. So the level of adoption we will see in the long term. Meanwhile, we can see the result of a survey given to the therapist and identify the disposition to use and the program's value as a clinical tool. Therefore, this selection of clusters of exercises was carried out by a group of therapists, allowing them to be participants of the decision in the selection of treatment. This way is intended to favor knowledge in a translational form through expert therapists and novices. We intend that novices improve their level of adoption by learning more simplified program, which is achieved through the use of this cluster of exercises. Thanks for your attention.
Thank you. We have 2 minutes for questions. Any questions? What do you think about artificial intelligence to remove this barrier, to train the platform?
Between therapists, among therapists. Yes, for us it was a difficult process because all the therapists they developed their different techniques. There are habit to practice to have the common practice. So to implement this kind of intervention, it was so difficult because many of them have not adherence to this kind of technology. But they have the intention to use. So I think that we need to simplify the tools to them because we need that they use too. It's not only an obligation, it's that to give collaboration from them, because the patients are the last user that they need this kind of technology to.
Thank you.
Thank you to Dr. Maldonado.